Hello, and thank you for joining the Center for Learning Health System Sciences for our monthly impact seminar. Before we get started, I'd like to cover a few expectations. Today's seminar will be recorded. You can enable closed captioning by hitting the Show Captions button next to the Raise Hand option in the Zoom menu. The public slide deck will be made available on our website under the Education tab, and I will post the link in the chat along with the short questionnaire that asks for seminar topic and speaker suggestions. Following the presentation, we invite you to raise your hand or type questions in the Q&A. And in particular, we welcome questions exploring the many dimensions of impact that these ideas, technologies, and practices have on learning health systems. As a reminder, for upcoming LHS events, the next seminar will be March 5th by Dr. Thomas K. Houston II. If you are in the Twin Cities area, the Department of Surgery and CLHSS are hosting Dr. Ho-Fung Poon from Microsoft Health Futures on campus March 18th through the 19th. I will post more information on that in the chat. And with that, I will turn it over to Dr. Genevieve Melton-Mukes to introduce our speaker.
Thanks, Stephanie. It is my distinct honor to introduce Dr. Stephen Bernstein here today with us for our impact seminar. Dr. Bernstein is the inaugural Chief Research Officer for Dartmouth-Hitchcock Medical Center. He's also the Senior Associate Dean of Clinical Research and Director of the C. Everett Koop Institute of the School of Medicine at Dartmouth. As the Chief Research Officer, he oversees all aspects of research at Dartmouth-Hitchcock Medical Center, including serving as the designated institutional officer for research and also leading the Hitchcock Medical Center's Office of Research Operations and really overseeing the development and implementation of forward-looking strategic planning for the organization's clinical, translational, and population-based research portfolio. In his associate dean role for clinical research for Geisel, Dr. Bernstein is responsible for growing and supporting the school's clinical and translational research programs, and also develops opportunities and processes for clinical and translational research that span across organizations. And then finally, in his role for the director of the C. Everett Koop Institute, he leads the Institute's efforts to advance health and well-being through research, education, and policy to protect the public health and to prevent disease. His research has really received extensive extramural funding from a broad range of agencies, including the NIH, particularly the National Institute on Drug Abuse, the CDC, and the Agency for Healthcare Research and Quality, as well as the Robert Wood Johnson Foundation. And really, if you go through just multiple additional accolades, really diverse journals such as Health Affairs, the American Journal of Public Health, all the way over to the Annals of Emergency Medicine. And again, a distinct pleasure to have him here. And with that, welcome you.
Thank you very much, Doctor. I'm delighted to be here. Happy to see all of you virtually. I made one trip to Minneapolis probably 15 years ago now. It was for a tobacco conference. I had a great time, and my wife went to medical school in Minnesota. So it's on our to-do list is to revisit your beautiful part of the country. Let me see if I can share my slide with you. And how's that working?
Looks good.
Yeah, okay, cool, thank you. Let me put it on the slide. Let's see here. Okay, is that all right?
Looks good.
Okay, great. So I want to speak with you for the next, I don't know, 45 minutes or so about a project that a while ago now, it's actually a decade, which amazes me. This was done at my former institution at Yale, which is why you see Yale all over the title slide. I've been at Dartmouth a few years now. I'm an emergency physician by training, but before that, I was actually trained in internal medicine initially, and then hematology oncology in New York City. And through that experience and some family history, I was interested in tobacco control and tobacco interventions, and I realized as a young internist in training and then an emergency physician in training, so I did another residency, that I was seeing lots of patients with tobacco-related illness, but we weren't really doing much of anything in the clinical arena to intervene, to screen them, to offer treatment, to make a referral, et cetera. We were treating all of the acute morbidities associated with tobacco illness, all of which you know. And so it felt somewhat unfulfilling to me, honestly. This is 30 plus years ago now, not to be more active in addressing the upstream cause of why my patients were coming to see me, either in the inpatient units or the emergency department of the hospital. So I started to think about tobacco control. And at that time in the late 80s, early 1990s, there was a new, at that time, new model in emergency medicine and other acute care settings of developing brief interventions for people with alcohol use disorders, what we now call SBIRT, screening, brief intervention, and referral to treatment, which I'm sure many of you are familiar with. And I thought maybe I could adapt that model for use in emergency medicine with my patients. And so I started to do some work in that arena, and that was my early focus of my research was ED-based interventions for people who smoke, and I did that for many, many years. But then, of course, I got interested in other clinical settings and looking to branch out beyond the ED. Most of the tobacco literature in clinical settings was done in outpatient settings, and I also knew as an internist in training that we weren't doing much on the hospital wards either, at least not a matter of routine. So I thought there was an opportunity there. So that was sort of the genesis of my career in this. And I'll show you this one study that in particular that we did a few years ago in New Haven. I want to acknowledge, first of all, the support we got for this from National Heart, Lung, and Blood Institute, and the wonderful team I had the pleasure of working with and still collaborate with some of these folks. I have no other disclosures. Everybody on this call knows that tobacco is the leading preventable cause of death and early morbidity throughout the developed world at this point. And brief interventions are effective, counseling, starting nicotine replacement products, et cetera. Lots of FDA-approved drugs. We don't need to get into all of that. But we know that in the inpatient arena, routine screening is often not done or done, let's say, in a cursory fashion. You may know that some years ago now, the Joint Commission and CMS started to require, actually the CMS, required public reporting of tobacco interventions for certain tracer conditions like heart attack and pneumonia. And then I was part of a group that did some work for the Joint Commission developing a measure set for inpatient tobacco treatment, a core measure set, which the Joint made optional, although some of us were hoping they would make it mandatory. So hospital-based interventions are still done kind of spotty. There are a few medical centers, mostly large academic medical centers, that have champions that might have tobacco treatment services. Maybe your site does one. And Minnesota's really done wonderful work in tobacco control over the years of people like Dorothy Hatsukami and Steve Fu. Anyway, smoking interventions here are often overlooked in the hospital. Nancy Rigotti at Mass General published a very important Cochrane review some time ago now that showed that if you want to do an intervention in the hospital for smoking, but you want it to be effective, in other words, to result in someone who's going to quit or abstain long term, that intervention needs to continue after they go home, which might sound, obvious in a way. It probably is, but most hospital interventions really stop at the point of departure, when the patient leaves. Nancy's meta-analysis showed that if you can develop interventions that persist for at least 1 month after discharge from the hospital, then the odds of that person becoming a long-term quitter or abstainer go up in a statistically significant fashion. So this is what I started to think about in the early 2010s. What can we do in the hospital to design interventions that would persist and maybe yield long-term smokers? It's a tricky thing because for all the obvious reasons, logistical reasons. What do you do with the electronic health record? How do you engage with private physicians or all the complicated outpatient settings and all the relationships that hospitals have these days, these very highly matrix kind of networks, demands on primary care providers, time, all these things. So not a simple task by any means, but I thought this was worth thinking about. And then also, how can you do this in a cost-sensitive way? Yes, you could say, well, let's just hire a bunch of counselors and make sure they call the patients and text them and all of that. But that takes real money. So I was also thinking, can we do this in a cost-sensitive fashion? So that was the objective of this study, to develop a package of interventions, study their clinical efficacy, look at their cost effectiveness, use the EHR as the sort of substrate in which to embed the intervention for these hospitalized inpatient adults who happen to smoke, and see what happens down the road. So I designed this as a hybrid trial, which I imagine many of you are familiar with, especially if you're interested in learning health system science. This is the typology developed by Jeff Curran at Arkansas, type 1, 2, and 3. So these are clinical trials where you're looking at both effectiveness endpoints, like did they quit, but also process endpoints or implementation endpoints. How many patients did you reach? What fraction of patients did you reach? Was it acceptable? Was it feasible? Et cetera. In a type 1 design, the focus, the primary endpoint is clinical effectiveness. The secondary endpoints are all of the implementation or process endpoints. And I'll get into more of that in a little bit. This was a two-armed study, and interesting to me, as someone interested in methodology, clinical trials methodology. This was not a study where we randomized patients or participants. We randomized the doctors for reasons that will become apparent. It's hard in a single hospital. This was not a cluster randomized trial where you have 20 hospitals and you can randomize by hospital. We had one hospital, and so how are you going to do that given that doctors float around, patients could be admitted anywhere? How do you define that doctor-patient dyad? Those are all interesting technical questions that I may get into if we have time. But we elected to randomize physicians, and also issues of contamination. If you randomize by patient, then you have to train the physicians. You only do the intervention with these patients, and with the other patients, you only do control. And that's hard. That's not necessarily something that comes naturally for an intervention that has at least some behavioral component, not like giving out a medication. So we randomized by provider. And these are the numbers of physicians, it was actually a little more, that enrolled, who agreed to enroll in the trial. These were inpatient doctors, largely hospitalists and internal medicine residents. The control arm, start with them, only received some academic detailing from me and my team, which basically meant a 10 or 15-minute presentation, either at a staff meeting of the hospitalists or at one of the weekly academic conferences that the residents receive. Just a little heads up about the study. The intervention arm, the treatment arm, received a package of decision support tools in EPIC, a bundled package of about four different things. I'll walk you through that in a minute. And that was not that the control doctors did not see this decision support platform. We enrolled just under 1,000 inpatients. All were adults, 18 and up, admitted to the medical wards. We excluded psychiatric, behavioral health, the labor and delivery, and the surgical wards too, and of course the critical care units, but still left us lots of wards. The primary endpoint was at 1 year. We'll get into that later. Now, the primary assessment of tobacco abstinence, and the whole study ran about 4 years. And we did biochemically verified cessation with exhaled carbon monoxide, pretty standard, with a number of secondary endpoints looking at use of our order set by the doctors. If you have any questions, by the way, at any point in the talk, feel free to put something in the chat, or I don't know, raise your hand, or however you want to do it. So these were some of the secondary aims, the implementation, endpoints. We did this at Yale New Haven Health System, a pretty large system, maybe about 1,000 beds, almost 1,000 beds at the main hospital in New Haven. At this time, we had just installed EPIC, actually, as our electronic health record. Well, again, interesting to me from a methods perspective, there were really two types of participants. I say subjects, it's an older slide. Today we would say participants. Two types of participants in this study: the healthcare providers and the patients themselves. So some interesting issues around human subjects and analytics and how all that works. And we figured it out. I walked you through this, just some of the, bright line data points about the hospital where we did this. Urban area, very diverse racially and ethnically, both staff and the patients. So take a little bit of time on this slide. It's a little busy. We'll hone in on details. So here's how it worked for this intervention we called e-stops. Most patients come into the hospital, unscheduled when they get admitted. If it's not an ambulatory procedure, if they get admitted to a medical ward, and most of them come in through the emergency department. So if a patient got admitted to the hospital, went upstairs to a medical ward, you know that in Epic, there is a place to note the patient's smoking status. Most patients have that filled out at some point, either on that visit or a prior visit to the institution. Luckily for us, in a way, Yale New Haven Hospital has a very large market share of all the good folk in New Haven. So very few people there who need inpatient care don't come to our attention, actually, or outpatient for that matter. So the clinical data warehouse is pretty complete in terms of not only the population of New Haven, but pretty good assessment of smoking status. And that smoking status is a searchable field, right? It's not free text. So we wrote code that would let us know if the patient who was admitted upstairs smokes or not. And if the patient was noted to be a smoker and the chart was opened up, the first doctor to open up the chart was randomized to the treatment arm, the intervention arm, the e-stops arm. This best practice alert would fire, BPA. I'm sure you all know that term. And the BPA did a number of things. It would automatically notify the patient's primary care provider that we were going to initiate treatment for tobacco. So that was passive. The inpatient doc didn't have to do anything. It would add smoking status, tobacco use disorder, to the patient's problem list if it wasn't already there. Remember, each of these interventions was designed, we would hope, to have an effect for at least a month after discharge. So if you put tobacco in the problem list, whoever sees the patient again, hopefully will see that. If you call the PCP, you contact the PCP through an in-basket message, it's not perfect, but at least you're telling someone on the outside. We made an automatic referral electronically to the Connecticut Smokers Quit line. All of this was passive. All of this was passive. And you can see those check boxes there in the light green box on the left, the BPA. So this was all basically opt out. In other words, the physician could unclick those boxes, but he or she had to do that deliberately. So this was all done as passively as possible. So we use a little bit of behavioral economic reasoning as well. The only active thing that the doctor had to do is an order. After the BPA fired, then there would be an order set. If the doc clicked accept, an order set would open up. You see it on your right there, the light blue box with sort of standard tobacco meds, just for the inpatient visit that the doctor could order. What you won't see there, by the way, is varenicline on the inpatient side, because I could not convince our Pharmacy and Therapeutics Committee to add it to the inpatient formulary at that time, which was around 2012. So those are the four basic functions: tobacco status added to the problem list, automatic referral to the quit line, notify the PCP, and the order set fires. And most of those are done passively. Here's an example. Again, you've probably all seen this. Forgive me. This has iterated over the years. It doesn't look quite the same today because of some other work we did with Epic, led by Mike Fiore. The choice architecture in this tobacco use box is, you see at the bottom, this is old now and it's overly complicated. But we tagged all of the smoking responses as indicators that we should fire the BPA when such a patient got admitted. So this is all programming, of course, that we did prior to rolling out the study. So for people randomized to the intervention, not for doctors randomized to the intervention, the charts of the patients they were treating, this thing would fire if they were a smoker. So that would allow us to follow what would happen to the people who smoke. And what about the control arm? This is a randomized study. The BPA doesn't fire for the doctors randomized to the control arm. How are we going to know what they're doing? Well, what we did, which was very clever, which means it wasn't my idea, is the programmer said, well, actually, we can have it fire. We just don't have to have the doctor see it. It just gets tagged electronically in the patient's electronic record that a smoker was admitted and treated by Dr. So-and-so, randomized to the control arm. And that's what we did. So the doctor didn't see the BPA. They couldn't do any of the functionalities through the BPA, but we knew that they had a smoker on their service, or, you know, any number of smokers. And none of this, mind you, precluded the doctor, any doctor, from prescribing on their own, a la carte, if you will, nicotine patches or gum, doing an old-fashioned fax referral to the state smokers quit line, calling the PCP if they wanted. They could have done all that on their own, but we didn't make it easy for them. They would have to do that. Any questions, please let me know. Again, here's a close-up of that best practice alert. You can see the functionality there: quit line referral, order set, problem list, and then the PCP notification is automated. The order set, this is just, you know, blown up standard meds. It's a little fussy, it's a little busy, but the basic nicotine replacement therapies are listed there, and some of the alternate drugs you see at the bottom, not widely used anymore, except perhaps bupropion, varenicline being the obvious missing drug. We made a brochure available. So the Connecticut Smokers Quit Line has this freebie brochure. It's a little old school, English on one side, Spanish on the other, and we just distributed these to all the inpatient medical wards of the hospital. We told the nurses, feel free to distribute these as you see fit, no questions asked, whether it went to control patients or intervention patients. We didn't care, or people who weren't even in the study. You want to give it out, give it out. And we did not include, for various reasons, nurses as interventionists in the study, nor advanced practice providers. And we can talk about that later if you have questions about that. Then the last bit of functionality I forgot to mention: when the patient was ready for discharge, ready to go home, we inserted some text here in the after visit summary, telling the patient, you know, you came in here, you smoke, here are some things you can do to help you quit, including the phone number for the quit line. This text was not tailored to their experience in the hospital. It's kind of boilerplate, but that's what we could do at that moment in time. And then here's the in-basket message. Now, if you know, for those of you on the call who work clinically, you know, we get all kinds of in-basket messages, and we, you know, read those and answer them with varying degrees of, you know, meticulousness. But we did send an in-basket message to the primary care docs. By the way, it might have been the case, you know, that maybe there was a patient in the study with a PCP who wasn't in our system at all. You know, maybe they were private practice somewhere. We still had a few. So this didn't work with perfect efficacy, but it was, we got the majority of primary care providers. So there were lots of technical questions that came up around building this order set. We did some user-centered design to build this. We had ideas about what we wanted, but lots of technical questions arose. So I worked with a group of hospitalists and some of the medicine chief residents to help me design this. Simple things like, should it fire right away? Should we wait a day or two? Because when the patients come in, maybe they're not in any condition to have a conversation about their tobacco use. There's some acute illness that you need to pull them through. If the doctor chooses not to engage with the order set right away or cancels it, doesn't accept it, do we want it to keep refiring? Patient could be in the hospital a week. Do we want it to fire multiple times a day, or should we just suppress it at some point because the doctors made clear that they're not going to use it, and we want to minimize their, the burden, the alert fatigue that we all can experience. So with working with the residents and the hospitalists, we agreed that we would fire it for up to 24 hours. It would start at the point of admission, just because technically that was the easiest thing to do. Our IT group had some concerns about a delayed fire, and then the internist working with us agreed that it could fire for the first 24 hours of clock time after the initial opening of the chart by the inpatient doc, and after that we would suppress it, just so that the doctor wouldn't have to be subject to multiple alerts. So it fired for 24 hours, and that was it. And then, as a way to sort of encourage, positive behavior, sort of positive feedback with the providers randomized to the intervention, to e-stops, we gave them feedback reports. I think this was, I think it was quarterly, monthly or quarterly, I don't remember. So we showed them how many times they, filled out, or how many times they accepted the order set, and which features they used, and how that compared to the mean of their colleagues. And this is all anonymized, of course, but sometimes these sort of little internal competitions is another way to encourage use, to encourage positive deviance, to try to push people to the, toward the behavior that you want them to exhibit. So we gave them some positive feedback. Another thing we had to do, or just general feedback, we had to work with the residents in particular, also the hospitals, but especially the residents, to make clear to them that there would be no adverse consequences for them if they did not engage much with e-stops. So we spoke to the program director, residency director, and of course he was on board, and we met with him and the residents to make clear there would be no issues of retaliation. For the hospitalists, we made clear this would not factor at all into your performance review. This was simply a research study. And also related to that, because the physicians were also participants, as I said, they had to give us written informed consent. So we did obtain written informed consent from the physicians in the study. Looking under the hood a little bit. So this is some of the work done by Michelle DeWitt, who is an outstanding programmer was on the EPIC team at that time, who built the logic that we would need in EPIC to be able to create these two sets of physicians. So EPIC itself did not do the randomization. When we spoke with when we did our roadshow with the hospitalists and the residents afterwards, those who wanted to sign written informed consent, we took their names, we randomized them, we told them which group they were in, and then we built these two lists of providers in EPIC, the interventionist or the e-stops group, and then the control arm. And that's how EPIC knew what to do. What that meant, by the way, is every patient, let's say Dr. Smith was randomized to e-stop, so every patient seen by Dr. Smith would then be exposed potentially to the BPA. They weren't randomized to the e-stops, but they could be exposed to it because their doctor was. And every patient randomized to Dr. Jones, who was an intervention doc, would not be exposed to this. And we had to think of interesting things like, what if a patient gets readmitted? or what if, one doctor goes off service, another doctor comes on service, and all. So we had a lot of interesting conversations around suppression logic and how that would work. And I can get into that nitty gritty later if you're interested. But we learned a lot about how to do this kind of study in EPIC, where the physician is the unit of randomization. So yeah, these are the groupers, as I guess it's called in EPIC speak. The groupers of intervention docs and the groupers of non-intervention docs. And this is work that we published in our protocol paper back in 2017. So the study ran for about, I don't know, 3 years or so. And we wound up enrolling 254 physicians. Their sort of career profiles you can see here. Most were internal medicine residents. I don't know, 20% or so were hospitalists. We had a handful of emergency medicine residents, only because at that time, they did some time up in the wards. So 254 docs, half randomized to each arm. This is a complicated slide and not easy to read, but from one of our papers, one of the reviewers wanted us to look at whether there was variation in use of e-stops by year of training, or how senior the physician was, resident versus hospitalist, et cetera. And I would say there were a couple of very minor differences in use of quitline, but this was more sort of exploratory analyses. And I think by and large, there were really no clinically important differences in how how physicians used e-stops as they became, more, as they moved further along in their training. Not much difference at all. Okay, so here's sort of the money slide for the implementation endpoints. So the first column of numbers is the e-stops group. The second is the control. So for every one of these, so way more meds were ordered inpatient from e-stops, lots more adding tobacco use disorder to the problem list, way more referrals to the quit line, email to the PCP. We didn't formally track for the control arm. There was no electronic way to do that. Anecdotally, nobody told us they did. So we don't know for sure, but we're pretty sure very few, if anybody, of the inpatient docs called the PCP to talk about their tobacco treatment. So strongly positive in terms of the process endpoints here, the implementation. Interestingly, by the way, you can see, and I didn't expect this, for like the quit line tobacco use disorder, it's actually a good bit less than 100%. So if you remember earlier, I told you that the doctors could unclick some of these boxes. So it looks like they often chose to do that. I didn't expect that, but even with the unclicking, because that's opt out. So if you made it opt out, you still wound up with a lot more recording of tobacco status, a lot more referral to an evidence-based behavioral intervention for smoking, the quit line. And not a bunch more, but more ordering of inpatient meds. So from the process endpoint, implementation endpoint, it looked like it worked nicely. That's the providers and their behavior. All right, now the patients. 1,044 patients we enrolled. The demographics you see here, very nice racial and ethnic diversity. This is largely a Medicaid population, as is typical for people who use tobacco. Median half a pack a day is what they smoke. And again, these are all people in the hospital. Some of their other data around tobacco use, alcohol, drugs, depression, et cetera. So the two groups were quite comparable. Okay, and here are the data unadjusted for the clinical effectiveness endpoint. Primary, again, 7-day abstinence, biochemically verified 1 year later, a year later. No difference. quit attempts. You see the intermediate endpoints at 1 month and 6 months. Change in daily cigarette consumption. Really doesn't look like the e-stops had any clinical effect, even though the intervention, that from an implementation perspective, seemed to work. In multivariable modeling, same thing. The first row there, the intervention. So this is e-stops with the control as the referent group. You see the 95% confidence interval crosses 1. No evidence of efficacy. What we saw is that advancing age increased the odds of quitting. That's an old finding. We know that. Being a non-Hispanic African American improved your odds of abstaining. Again, no evidence of clinical effectiveness of this intervention, even though all of its components ostensibly should have lasted for more than a month. We did some qualitative work with the patients and staff. Afterwards, this is adapted from the rubric we used was adapted from a paper by Stang and Russ Glasgow. And some of the, you can see here some of the features around implementation that we had to consider in designing this. We thought we were minimizing provider workload. We thought we were giving some limited amount of choice. We thought we had a teachable moment. So, you know, a couple things about the clinical work that we did, or the clinical results, I should say, which we published a few years ago. For one thing, I'll head back a bit here. The quit rate or abstinence rate in the control arm was a lot higher than we anticipated. We thought it was 11%. We thought it would be in single figures, you know, based on prior work that we'd done. And others. This happens sometimes in behavioral trials. It happens in multi-component behavioral trials, as ours was. And again, as you know, in tobacco control, since the medications are available over the counter or from quit lines or from any number of sources, the control arm actually might have been receiving, you know, treatment that we weren't aware of. We did some assessment of that afterwards and didn't find much difference. But a more important methodologic concern, which I had, was, again, this intervention lasted for the duration of the inpatient stay, certainly. And it probably did last for a few weeks or something after, you know, they went home, hopefully. But we were asked by NIH to make 1 year the primary assessment for cessation, which we knew was way distal to the intervention and almost certainly way distal to when the intervention was likely to end. So we were nervous about that. You know, I wasn't crazy about doing that, but that's something that we were asked to do. So, you know, it wasn't really, we didn't have much choice in the matter. So we did that. And again, this is not uncommon in tobacco treatment trials. It's a little different from how other drugs or alcohol are even assessed. Oftentimes the assessment is way distal to when the intervention ends. So I thought, all right, maybe we'll see something at a month. You know, we did. But if you look at the 1 month assessment there, the third row, even there was no difference. So that was pretty disappointing to me, you know. But, you know, we have what we have. There's a question, what happened to this clinical decision support, how we handled de-implementation? So it was de-implemented. I will tell you, it was de-implemented largely because it didn't work. We didn't have good evidence that this was worth continuing. And so we had to rethink things. Had it shown effectiveness, I think the institution would have considered, you know, keeping it and even expanding it. but we realized we didn't have a good enough product. So we had to go back and rethink this a bit, is how I would answer that question. Let's see if I can, okay. And I can get into more of the, the technical aspects of this, which even though it was a disappointing result in a way, we learned a lot in the process of doing it. One, we learned that, first of all, success depends on your definition of what's success. Had we powered this as a type 2 or a type 3 hybrid design where, the implementation endpoints are either co-equal with the clinical endpoint or the primary endpoint, it would have been a positive trial, because we got the implementation to work so nicely. But because it was type 1, strictly speaking, we didn't reach our, we didn't find what we were hoping to find. We also learned a lot about how to do clinical trials in Epic with randomization and working with providers as the unit of randomization. That was kind of neat too. The other thing that I learned, which is, I'm sure, I know germane to your work also as a group of people interested in learning health system science, is how do you even get approval? How do you get buy-in from the stakeholders in your organization to even do such a thing? Because in a way, it was a pretty audacious study to do in the context of a busy acute care hospital. We had to involve multiple clinical services, the IT department, which at that time was really busy installing Epic throughout, the entire healthcare system, not just at the mothership in New Haven. We had to gain the confidence of the hospitalists that we weren't going to, give them yet one more unfunded mandate to do. We had to do the same thing with the residents and handle their professional concerns about retaliation or getting in trouble, so to speak, if they didn't do it right. We had to address concerns of nursing staff and APPs as to why they weren't part, why weren't they, interventionists in this as well. So there was a lot there to think about, and so that led me and some of my colleagues also to think about how we do stakeholder analysis in these kinds of studies. And what I felt or came to believe is that I felt there were certain shortcomings in current methods we have for stakeholder engagement and stakeholder analysis, because I felt they did not pay sufficient attention to issues of power, organizational power, and who has the ability in the institution to greenlight a project, to whose support is critical, whose support is not so critical. And it's not always who you think it's going to be. So I started to think about this, and I tend to think visually. I thought, is there a way to map this in a way that I can understand? And so what I wound up doing was building an organizational chart for the hospital or the health system that's on your left there, and also for the medical school, because obviously it's the medical students, medical schools, physicians, and trainees who are working in the hospital, and IT crosses both. So, and every box you see here is, other than the gray ones, are people I spoke to in the course of setting up this study, just trying to get the buy-in from all the key stakeholders to allow me to proceed. And what I started to do, kind of informally, as I built this org chart, is I would then, color in, once I spoke with someone or a group of people, how supportive I felt they were, using standard sort of, traffic light, yellow, green, red, to gauge their level of support. And then also, I realized, who are the people who were most critical to have on the team, irrespective of their level of support. And that I noted that by the thickness of the border of the boxes that you see there. And the thicker the border, again, those are the people who are most critical to the project. So on the left, and then somewhat to my surprise, some people were less important, and I didn't realize that at the time. This only came in the course of doing the project. And clearly, because the hospitalists were such a large group of providers, and I really needed them on board. So they were critical to doing this. In fact, one of the hospitalists, I offered him to be part of our team. I made him a co-investigator, and he got some publications out of it. And he's now actually, I think, a director of quality improvement for the hospitalist group, because he got really turned on by what he did in this study. So much of this study is embedded in IT, as you see there. So the chief medical information officer was critical, the CMIO, and he had a dual report up through the hospital system and through the med school, and the IT group, of course, that worked with him. The internal medicine was most critical, because again, the hospitalists and the internal medicine residents. So the program director, chief residents, you can sort of see this for yourself. I had to work with the Quitline group and the State Department of Public Health, because the Connecticut State Department of Public Health had the contract with the Quitline vendor. They're based in Seattle. And so I actually had to convince or assuage concerns of the State Department of Public Health that we would not be inundating the Smokers Quit Line with more referrals than they could handle, or more referrals than they had paid for in their contract, which I thought was kind of interesting, and that the state was worried that we might be too successful. So I had to speak with them, Quitline. It all worked out. But this method, which I came up with, this acronym COSMOS, you see there, I thought could be an interesting way for someone planning an implementation project to identify the local stakeholders, map them not only in terms of their where they stood in the organization, but also their criticality to conducting the project as well. And this paper I published in Implementation Science a few years ago. There were lots of lessons learned from this. It took us about a year, I think, to get out in the field. I think we had anticipated about 6 months. And as I'm sure you know well, anything you want to do with IT, it's going to take longer than you think it will. And there are going to be, hiccups that you hadn't thought about. You can randomize by provider. There is functionality now in Epic that makes that easier. And again, a lot of methodologic issues that we had to address, some of which we discussed already in this talk. I didn't mention readmissions. So, this came up also. Let's say somebody was randomized on their index admission to a control doc. They're not exposed to e-stops. They do okay. They go home. A couple months later, they get readmitted. What happens if they're randomized now to an intervention doc, an e-stops doc? So we actually suppressed it. So if you were initially randomized to a control doc on your first admission, e-stops would be suppressed for all subsequent readmissions to the hospital. Whereas if you were randomized to an e-stops doc on your index admission, if you got readmitted, we would let e-stops fire if such a doctor was going to take care of you. So we had to, avoid that kind of cross-contamination. And the nurses we engaged with brochures and asking them to do what counseling as they saw fit with individual patients. Again, because of the issues of contamination, nurses care for multiple patients. It didn't seem feasible for us to include nurses in the randomization scheme. It would have added a layer of complexity that was beyond what we could have managed. So for better or worse, nurses and APPs were not included as units of randomization in this study. And that's, I think, the formal part of what I've got for you. So I'll stop the share there. And any questions, I'm happy to take them.
Yes, thank you, Dr. Bernstein. We have just a little under 10 minutes remaining for Q&A. So if there are questions, I'd ask that you either put them in the chat, enter them in the actual Q&A, or if you want to raise your hand and ask a question verbally, that would be fine as well. Anyone who would like to ask their question first? While we wait for some questions to come in or hands to be raised, maybe the most obvious question, what would you say is the most important single takeaway from your talk today for our audience?
Yeah, that it's for this kind of work is hard. It's fun to do. It's very hard to do, and it takes a lot of resources. And I've started to think that there's no such thing as a low tech or low intervention way to do this work. In other work I've done and others, old fashioned things like bedside counseling of patients is clinically effective. I was hoping I could develop something that would be low cost and therefore easily scalable for places that don't, that aren't large academic medical centers or don't have tobacco teams or, these kinds of folk available. There may be a way to do that using IT and digital tools alone. And there might be. I didn't find it in this study, and it makes me wonder if functionality only using the electronic record is going to be sufficient for us to develop sustainable, successful interventions for people who smoke. But that's a useful lesson too.
Yeah. Okay, Dylan, I have given you talk ability.
All right. Yeah, my name is Dylan Crimes. I'm at the University of Victoria in Vancouver Island, BC, Canada. And I had some projects back in 2012 with EPIC on some module for behavior change for diabetes type 2. And they called them BPAs as well. I just was kind of my background's in IT. So I was just kind of going through the transcriptions of them using it, think aloud protocol and stuff like this. Your presentation is excellent. You went one step further from the BPA and understanding like a month later, the clinical effects. And like you said, it was kind of disappointing that there was no clinical, I don't know, the whole aspects around it because I'm not a clinician. I'm a health informatician, assistant prof in health informatics. So, but I was thinking maybe there's a way to there's a ratio or like some way to kind of capture some sort of benefit after this use, not just straight numbers, but a percent or ratio. And also like for the module for example, for the module for EPIC was how many steps, did they, and they tracked it over a couple weeks. In the module, I didn't go clinical, but maybe there's a way to do that in this tool as well to see some effect of the smoking cessation.
Thanks for your question, Dylan. Thanks for listening in. I think you might be right. We were powered, for a clinical delta of, I don't know, 4 or 5%, something like that, and the difference in tobacco quit rates. Maybe there's a 1% improvement that, so if we had, tens of thousands of patients, maybe we could have found it. The clinical data I showed you on cessation was, based off of the 1,000-person subsample who we did, long-term follow-up on. The data I showed you, how many times the BPA fired, was used, quit lines, et cetera. We had a registry of, I think, around 11,000 patients. So we have very, very good, info on the use of the BPA and its attendant functions as well. It could be the case that if we just let this fire, for a couple of years, we might see some modest clinical effect. That could be, maybe we're just underpowered. I don't know.
What about like a BPA and then there's a track, there's like a track, sort of a calendar in there that says yes or no, quit smoking or reduce smoking, that kind of progressive kind of notes. Is that something that you guys considered?
Not at that time. You could do that. It gets tricky when you put the onus on providers to be the ones to document tobacco status with some regularity, even though we're supposed to do it, but in the press of business, it doesn't always happen. And then, it has to be a searchable field. You could probably do stuff with natural language processing and, that kind of stuff to do it.
And this is hospital setting too, right? Not primary care.
Correct. That's right. That's right. Yeah.
Cool. Very cool. Thank you.
Thanks a lot.
Okay, we have one more person with their hand raised. Melissa, if you want to ask your question, and then we'll end after that.
Hi, yeah, thanks for the talk. In learning health systems, there's a focus on this kind of cycles of improvement, iterative improvement. Was there any sort of discussion to investigate in this case why there wasn't a clinical success with these interventions, and kind of in that context of thinking about iterative improvement?
Yes, thank you for the question, Melissa. Yeah, we did discuss that a lot. I think there were a couple of things. One, again, the quit rate in the intervention arm was higher than we expected, probably just a phenomenon of getting people into a study, behavioral study, and they tend to improve their behavior anyway. There was some of that, but beyond that, one issue that came up. I don't think we sufficiently engage the primary care providers. So if I were going to redo this or do this 2.0, I think we needed to do a better job other than an in-basket message, which probably just goes into the ether. I think we needed to pull them in. So at that time, most of our PCPs are concentrated either in hospital-based clinics or two local federally qualified health centers, or a couple of large multi-specialty groups in the area. So we probably could have made a concentrated effort to do some academic detailing with those groups, and bring this study to them. I think that might have made a difference. So if I was going to do this again, I think that if I could just do one thing, it would be deeper engagement with the PCPs for follow-up.
Hey, once again, thank you very much for your time today and your presentation. As a reminder to all of our attendees, our next seminar will be on March 5th at noon Central Time. And this concludes our presentation for today. See you next time.
Thanks, everybody.
Thank you.